Sir, we are live now. Sir, with all your permission, shall we start?
Yes.
Okay, sir, thank you. Good evening, everyone present. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Professor Dr. Umesh Khurana, sir. Sir has a professor at CCM Government Medical College, Durg. And today, sir is going to discuss on a topic, neonatal resuscitation. Let me tell you overview of the topic. Neonatal resuscitation, also known as newborn resuscitation, is a life-saving emergency procedure used to save the 10% of newborns who do not start breathing right away and they therefore at risk of suffering irreparable organ damage or even passing away. Medical staff can encourage newborn to start breathing on their own by applying positive airway pressure and in the extreme circumstances, chest compression. To learn more about this topic, I would like to invite Umesh Khurana, sir. Sir, over to you. Kindly proceed from.
Good evening. Are you seeing the screen?
Yes, sir, it's visible,
Hello.
sir. Perfect.
Okay, fine. So I take this opportunity to thank MedTalks IGCP group for giving me an opportunity to make a presentation on this very important subject of resuscitation of newborn this evening. Well, we all are delighted when at birth there is an active newborn baby. The mother is happy, the pediatrician is happy, the obstetrician is happy, and there is happiness everywhere. And this is achieved, cry is achieved, because the baby is now independently ventilating himself. And ventilation of the baby's lung, that is the function of the lungs, is the most important and effective action in newborn resuscitation. The dictum is that we are all doctors, we are professionals, we are nurses, we are professionals, and our goal should be to give a breath and to save a life, because this is really a medical emergency. The question is why, after all, we should learn a resuscitation of newborn. Well, around 20% of all neonatal deaths take place because of birth asphyxia, that is lack of oxygen. And if we resuscitate timely by appropriate resuscitation, thousands of newborns, the outcome can improve. We can save their lives, or we can decrease the morbidity. 10% of the babies, they require some resuscitation, and 1% may require active, extensive resuscitation. Well, this is the story when of the intrauterine life, where the mother is taking oxygen, mother is having her own respiration, and through uterine arteries, oxygen is delivered to the uterus and it comes to the placenta. And from that placenta, oxygen goes to the growing baby within the womb, and carbon dioxide is passed out from the placenta. So there is a gaseous exchange at the placenta level. So placenta is acting as a, you can say, ventilatory organ during pregnancy. This is what is the fetal circulation like. Important thing is that the lungs are not functioning. There is no need for the function of the lungs have developed, but the lungs are not expanding. And the blood, it is coming, the oxygenated blood is coming from the placenta through the umbilical vein. It is going here like this. It enters into the right atrium, and from there directly comes to the top and is supplies to the brain. And then the impure blood is passed like this, and through these umbilical arteries, the impure blood goes to the placenta, and so carbon dioxide is passed out like this. Important is that the lungs are not expanding during the intrauterine life. There is oxygen for fetus from mother's blood. Just a small fraction of fetal blood passes through the lungs. The fetal alveoli are filled with fluid and vessels are constructed. Blood flows primarily through an alternate route of ductus arteriosus into the aorta. So this is what is there. Before birth, these are the alveoli and they are filled with fluid. They are filled with fluid. And around that, there are blood vessels which are constructed. What is happening before birth? The blood is passing from the ductus arteriosus into the aorta. So this additional conduit is there, ductus arteriosus, which is operational during the fetal life, ductus arteriosus. But at birth, three major changes take place. The baby is born. The lungs get expanded. And because the lungs are expanded, there is a decreased resistance to blood flow. The fluid which was there in the alveoli is absorbed, and this is replaced by air, which is there in the environment. The umbilical arteries and vein are not needed now. They are clamped and they are constricted. So we don't need now the umbilical arteries and vein when we are born. So gradually, what will happen? This fluid will be replaced by air. And now these constricted blood vessels, which were compressed, they start getting increased in size, they start getting dilated. We don't need now at birth or after birth, ductus arteriosus is not needed. And so this ductus arteriosus closes and blood is going down to the lungs. So a normal neonatal circulation is established for our lives. So the changes at birth are that this fetal lung fluid is replaced by atmospheric air. This is, say, you can say the first breath, second breath, subsequent breath, and we have got good quantities of surfactant so that these alveoli, they remain open. They remain open, and the baby continues to cry, continues to live. But something odd can also happen. If there is oxygen deprivation, if there is a hypertension in the mother, some problem in the mother, placenta gets separated. If there is oxygen deprivation, respiration will be first to cease. And what will happen? There will be primary apnea. Apnea means no respiration. The baby takes some breathing. And then there is no respiration. It is called as primary apnea. If oxygen deprivation continues, nothing is done. The baby enters into secondary apnea and may require positive pressure ventilation. Otherwise, the baby will die. This is exactly what happens. There is initially a compensatory rapid respiration when there is a lack of oxygen. Then the baby enters into a stage of primary apnea. In this stage, there is compensation. The heart rate starts increasing. The blood pressure starts increasing. But if no oxygen is given, the delivery is not terminated. बच्चे को fetal compromise हो गया है. ऐसी सिचुएशन में अर्जेंट सिजेरियन सेक्शन नहीं हुआ, अर्जेंट डिलीवरी नहीं हुई, बेबी को बाहर नहीं निकाला गया, the baby will continue to have gasp, and the baby may develop secondary apnea, and the baby can die in utero. Andar hi, before birth, the baby can die, and this will be a stillbirth. Or the baby will be getting a birth, secondary apnea, severely asphyxiated. At this point, there will be a fall in heart rate. The blood pressure of the baby, of the newborn, will be low. And unless and until a team resuscitates, the baby will die. So, asphyxia, therefore, is a Greek word. It means stopping of pulse. It is a condition due to lack of oxygen in respired air, resulting in impending or actual cessation of apparent life. Asphyxia is the most likely complication which can occur at the time of birth. And therefore, a Latin word is resuscitate, that means to arouse again. We don't want the baby to die. So we do a skillful resuscitation of the asphyxiated newborn. If done properly, if done well, if done in time, if done by a skilled person, it can prevent brain damage and can minimize subsequent neonatal morbidity. So how to do? Ministry of Health, Government of India has a Navjat Swasth Shishu Karyakram, NSSK Karyakram. And under this Karyakram, there is the algorithm. And this is the algorithm, which has been also approved by Indian Academy of Pediatrics and National Neonatology Forum of India. And this is what we have to follow in every delivery. We have to note down the time. We have to dry the baby because the baby is having amniotic fluid all around. And then after drying, what we have to do if the baby is crying, we have to offer skin to skin care to the baby. That means the baby is kept for skin to skin care in between the breasts of the mother. Routine care means that the baby is delivered onto the mother's abdomen, except for cesarean section, when the cord is clamped between 1 to 3 minutes, and then the baby is shifted under radiant warmer. If baby is crying well, everything is fine, then mother is counseled, motivated to start breastfeeding after some time. The breastfeeding should start positively within half to 1 hour after birth. However, if the baby is kept under radiant warmer, airway maintenance is done, suction is done, and then some stimulation is offered. After stimulation, the baby can cry and we assess the breathing. If the baby is breathing well, in that situation, we cover baby and mother together, offer skin to skin care, initiate breastfeeding, and examine the baby every 15 minutes for any further decline in heart rate, any problem in breathing, or change in color. But if the baby is not breathing at this time, say after 30 seconds after birth, then we have to initiate bag and mask ventilation, initially with room air. First, we give 5 ventilative breaths. If there is no chest rise after 5 breaths, then we offer bag and mask ventilation continuously for 30 seconds and assess again. Generally, the baby will cry. The baby is breathing well. And then we initiate the breastfeeding. But if the baby is not crying at this point of time, we continue with bag and mask ventilation. We add oxygen. We call for help. And then we may have to give additionally chest compressions, intubation, and some drugs. And after this, we may have to shift the baby selectively. Few babies may have to be selectively sent to NICU. So this block of initiating bag and mask ventilation, this block is needed by around 10% of the delivered neonates. The remaining 90% are fine. TABC of resuscitation. Temperature maintenance is very, very important. A is for airway. The airway should be clear, the secretions should be sucked out. The baby should have a normal breathing. Circulation should be good, and the heart rate should be more than 100. The baby should be pink, the body should be pink, and the periphery can be bluish, but the body should be pink, and the heart rate should be more than 100. And lastly, if the heart rate is less than 100, in that situation, sometimes after chest compressions, we may have to give certain drug, and the drug may be epinephrine. But that is, we are not discussing that today. What we are discussing today, with the limited time, you know, friends, that neonatal ventilation, we have workshops for 1 complete day. That is NRP program. And in this webinar, we have only 1 hour. So we will be discussing on positive pressure ventilation. In this lesson, we will learn when to give positive pressure ventilation, what is the correct way of placement of mask on newborn's face, testing and troubleshooting of the bag, evaluating the success of bag and mask ventilation, and we'll be also talking about TPs ventilation in the labor room. So after 30 seconds of initial steps, if the baby is not breathing, that is apneic. If the respiration is gasping or irregular, if the heart rate is less than 100 per minute, and if the baby is cyanotic or if the baby is blue, we have to start with bag and mask ventilation. We've got two sets of equipments. One is called as a self-inflating bag. This bag fills spontaneously after it is squeezed. We start with room air resuscitation, and we can add oxygen through reservoir. The second equipment is a T-piece resuscitator. In this, the gas flows into it, and the gas is directed to the baby by occluding the T-piece opening. So this is how the self-inflating bag looks like. This is a self-inflating bag. This corrugated tube is a reservoir. There is a oxygen, there is a small oxygen inlet here where oxygen can be connected. But this, we connect the oxygen, but we can start resuscitation with room air. There is a pressure release valve which pops off after 35 centimeters of water pressure. This is a valve assembly, and this is a place where the mask is attached. The advantage of self-inflating bag is it refills after being squeezed, even without gas. So therefore, it can be used in any place. किसी भी गांव में, किसी भी जगह में, कहीं भी without oxygen भी इसको use किया जा सकता है, self-inflating bag. And there is a pressure releasing valve, जिससे कि there is no risk of barotrauma because of pressure release valve. The disadvantage is that whenever there is a lack of oxygen, you require an oxygen source and a reservoir. It cannot be used to deliver free flow oxygen. So the problem is related to oxygen delivery, and this equipment cannot deliver CPAP, and therefore this equipment cannot manage critical, very serious babies who are having asphyxia. The size of bag is 240 to 750 ml. It can give oxygen from 21%, which is air, to maximum 90 to 100% oxygen. There is a pressure release valve capable of avoiding excessive pressures, and there are various types of masks, appropriate size masks, one for term baby and the other for preterm baby. So a 240 ml bag, a 750 ml bag. So these are the two sizes which are freely available. So what are the parts? One, this is an air inlet with oxygen reservoir. If we don't attach the air inlet, 21% oxygen goes in, room air resuscitation is possible. Two, there is a small tubing here, a small nozzle here called as oxygen inlet. And here we connect the oxygen. Three, there is a patient outlet. Here the mask, we fit the mask. Fourth, there is a valve assembly. This is a valve assembly
So when we compress, the gas or the air passes in. And when we don't compress, nothing happens. Then there is an oxygen reservoir. This is a corrugated tube. There is a pressure release valve, a pop-off valve here. And there is a pressure manometer site also, but generally here, but we don't use that pressure manometer site. Generally, we don't use it. So suppose there is no oxygen reservoir. So room air resuscitation is taking place. 21% oxygen is without oxygen reservoir. And suppose we connect this oxygen reservoir and also connect oxygen, then we can give 90 to 100% oxygen to the patient. Oxygen reservoir can be in the form of corrugated tube, or it can be a closed system, a closed bag. This can be attached to the air inlet. The pop-up valve is set at around 30 to 35 centimeters of water. There is a port to attach a manometer, but we generally don't use it. The masks are cushioned, and these cushioned masks are less traumatic. They fit nicely. The shape can be round or anatomical, and the size can be a term mask or a preterm mask. So these are the shape. This is a round mask, and this is a anatomical mask, depending upon the shape. What is important is that when we put these masks, there should be no gap between the mask and the chin. It should be fitting very well. The chin should be covered, the mouth should be covered, and both nares should be covered, and the mask should not cover the eyes. The eyes should be protected. So therefore, this is incorrect because there is a gap here. This is correct. No gap, mouth is covered, nose is covered. And this is incorrect because it is above the chin. So this is the correct way of wearing the mask. So we have to have a oxygen tubing and oxygen reservoir before we give PPV. We have to adjust the flow to 5 liters per minute. We have to fix the face mask properly. We have to open the pressure release valve. And we have to check whether the equipment is fine or not. So we block the patient outlet of the mask by the palm of the hand, squeeze the bag, and feel the pressure against the hand. This is how. So this is the mask. We are keeping the mask onto the palm, applying a pressure. And when we apply the pressure, we feel a pressure, gas is due to gas. That is to say that the self-inflating bag is okay. Sometimes we can apply a manometer, but we don't use the manometer. So we have to select the appropriate size mask. Be sure that there's a clear airway. That means after doing suction, we apply the bag, position the baby's head, and position properly yourself, the resuscitator, at the bedside. So this is the correct position of the resuscitator. This is the head end of the baby, and this is the resuscitator. But this is the incorrect way. The head is far off. And because of this bag, she cannot see what is happening here. This is the wrong position of the resuscitator. The correct positioning of the mask, you see here, you see there's a gap here. There should be no gap here. Otherwise, कितना भी pressure लगाएंगे, वो हवा यहाँ से निकल जाएगी. So there has to be no gap. When we give positive pressure ventilation, suppose after applying the mask, we give 5 breaths. So there should be a change in heart rate. There should be a rapid rise in heart rate. There should be a chest movement. There should be improvement in color and tone. And if we auscultate, there should be audible breath sounds. The normal lung has a pressure of around 15 to 20 centimeter. Initial breath, it is around 30 centimeter. But diseased lung, say hyaline membrane disease, they require a higher pressure up to 40 centimeter of water. What should be the frequency of ventilation, bag and mask ventilation? It should be around 40 breaths per minute. It is not per day, it is per minute. It's the error. 40 breaths per minute. So the formula is breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. So when we say breathe, we press the self-inflating bag. And during 2 and 3, there is relaxation. So breathe, 2, 3. Breathe, 2, 3. Like this, we do 40 breaths per minute. Suppose we give for 30 seconds, that is 20 breaths. What will happen? The heart rate should improve. And if the heart rate is more than 100, the color has improved, the baby will start crying. There is spontaneous breathing and the muscle tone will increase. Suppose there is no chest rise. The heart rate is not picking up. So what to do? We have to remember this Mr. SOPA. M is for mask. Check the mask. Check the seal. Because if the mask is not properly placed, the pressure will not be there. And therefore, the heart rate will not be improving. So step 1 is check for the mask. R is for repositioning, position. There is a possibility that the baby may have shifted. The position may not be good because the baby should be in a sniffing position. So R is for repositioning. S is for sucking the secretions. So we have to suck the secretion. O is that we have to open the mouth, open the mouth. P is the pressure may be less, so we have to increase the pressure. So we have to increase the pressure. And A means prepare ourselves for an alternate method of resuscitation, example, intubation. Because sometimes if the baby's heart rate is not picking up, in the 1% situation, we may have to intubate. So if the baby is not improving, check the face mask, check for the positioning, suction, do suction of secretions, and increase the pressure, If the baby is not improving, in that situation, we may have to attach oxygen to the oxygen inlet source, and we have to see whether oxygen is flowing through the flow meter. So self-inflating bag should have an oxygen reservoir, and we can give oxygen if the baby is not crying, say after 30 seconds of resuscitation. Now this is a T-piece resuscitator. This is called as Neopuff. This is manufactured by a company, Fisher and Paykel, which is a company of New Zealand. You can see this dial, and we have to keep the pressure of inspiration up to say 30 centimeter. In this case, at present, this is 20. We will just see how to use this T-piece resuscitator. Every labor room should have a T-piece resuscitator. Now, this is a T-piece resuscitator. We have to have some controls here for managing the pressures of inspiration and expiration. There is an inlet and there is an outlet. So we connect this to a gas source, and we connect this at a rate of, say, 6 to 8 liters of oxygen. So gas is coming like this. This is the gas outlet. And here we connect it to the mask. And there is a T-piece here. This is a T-piece, which this we control the respiration. We provide ventilation using this T-piece system. What are the advantages? The advantages are many. It offers positive and expiratory pressure. T-piece resuscitator gives a reliable control of proximal inspiratory pressure and PEEP both. It can help in oxygenation with a lower FiO2. Very easy to operate. There is no fatigue from bagging. And it can be used as a transport ventilator. So this can be used as a transport ventilator. Very useful. The disadvantage is it requires a gas supply. But then, everywhere now we have got gas cylinders. तो कोई समस्या ज़्यादा है नहीं. It requires prior setting of pressures. Very easy to learn. सीख जाइए, बन जाएगा. So the basic thing is a investment cost of equipment, and that cost is not also very heavy if we consider that life is priceless. Now focus on this curve. This is a pressure time curve. On the x-axis is the time in seconds. So there are two types of curve. One is a blue curve. This is a blue curve with self-inflating bag. And if we see the curve, the pressure is increased with self-inflating bag, we have seen, to say around 40. And when we release, it comes to 0. So the pressure is just like 40, 0, 40, 0, 40, 0. It is like this. So PIP is very high. And it has been found that when the pressure is dropped down to 0, there is no PEEP. Positive and expiratory pressure 0 यदि रहता है, तो एल्वुलाई कोलैप्स्ड रहते हैं, एल्वुलाई खुलते नहीं है ज्यादातर। अब ये क्या करेगा, इसमें सी द रेड कर्व नाउ, द प्रेशर इज ओनली 20, हमने 20 प्रेशर से ही हम काम कर रहे हैं, 20 प्रेशर, और पीप हमारा है 5, तो इट इज 20/5, 20/5. This is given by TPs, 20/5. ज्यादा प्रेशर नहीं है तो बैरोट्रोमा नहीं होगा, और 5 रहेगा, 0 पे नहीं पहुंचा तो एल्वुलाई ओपन रहेंगे। तो दिस रेड वाला जो कर्व है, दैट इज ऑफर्ड बाय दिस वंडरफुल इक्विपमेंट, द TPs resuscitator. This is a product of New Zealand. There are various size of mask which are available. This is the code of mask. ये देखिए मास्क है, ठीक है ना, इसके अलग अलग साइजेस आते हैं। सेटिंग करने के लिए क्या करना है, ऊपर का जो वेल्व है इसका टीपी, दिस इज द टेस्ट लंग, द ब्लैक लंग जो है इज अ टेस्ट लंग। ऊपर से अंगूठा लगाइए, बंद कर दीजिए, तो यहाँ पर ये जो है, ये डायल है, इसमें ये मूव करना शुरू हो जाएगा। इसको यहाँ से घुमा के सेटिंग कर दीजिएगा, से ब्रिंग इट टू 20 पे ले आइएगा और छोड़ दीजिएगा। पीप को एडजस्ट करने के लिए इसके ऊपर जो है इसको थोड़ा सा मूव कीजिएगा एंड सेट कर दीजिएगा पीप को 5 पे। सो वेरी सिंपल सेटिंग्स, इसमें सेटिंग करनी है और ये ऊपर इसके जो इसमें सेटिंग करनी है, एंड दिस इज द टेस्ट लंग, वेरी इजी टू डू। सो वी कनेक्ट द इंस्ट्रूमेंट, यहाँ पर गैस सप्लाई में कनेक्ट कर दिया हमने, सिलेंडर, ये देखिए सिलेंडर है, वी हैव कनेक्टेड टू द सिलेंडर। यदि आईसीयू में है तो यहाँ पर हमारे पास में हम ऑक्सीजन भी है और एयर भी है, तो ब्लेंडर लगा के भी हम करेक्ट कर सकते हैं। ईदर वी कैन गिव 100% ऑक्सीजन थ्रू सिलेंडर, और वी कैन गिव ए विद द हेल्प ऑफ ब्लेंडर। गैस सप्लाई को हम एडजस्ट कर देते हैं बिटवीन 5 and 15 liters per minute. Suppose we adjust it at say 6 liters or 8 liters. We resuscitate by placing and removing the thumb. ये thumb है, जब हमने इसको दबा दिया यहाँ पर तो चेस्ट राइज शुरू हो जाएगा। जब इस thumb को ऊपर कर लिया तो एक्सपिरेशन हो जाएगा। इसको यहाँ पर क्लोज कर दिया तो इंस्पिरेशन हो जाएगा। तो जस्ट थंब से ही हम इसको ऑपरेट कर सकते हैं। सो वी हैव टू फिट द टीपीस, ये एक्सपिरेटरी वाल्व हो गया, मास्क लगा दिया, और फिर यदि हमको इसको ट्रांसफर करना है किसी सीरियस बच्चे को, तो एंडोट्रेकियल ट्यूब डाल के हम इसके ऊपर से इसको एंडोट्रेकियल ट्यूब से कनेक्ट कर देते हैं। सो दिस बिकम्स अ ट्रांसपोर्ट वेंटिलेटर। सो दिस इज हाउ आई एम यूजिंग द T-piece resuscitator on a mannequin। ये देखिए साहब, ये मेरी उंगली ऊपर है, इसका मतलब एक्सपिरेशन हो रहा है, और जब मैंने इसको बंद कर दिया तो इंस्पिरेशन हो रहा है। बंद करेंगे इसको तो इंस्पिरेशन है, और इसको ऊपर निकाल लेंगे तो एक्सपिरेशन है। इंस्पिरेशन, एक्सपिरेशन। सो नाउ friends, we have come to the last slide. If after 30 seconds of effective positive pressure ventilation with oxygen the baby is not improving, मतलब वो हम जो है, जो एल्गोरिदम के नीचे पहुंच गए, heart rate is still less than 100, we continue with positive pressure ventilation, but this time we call an expert क्योंकि अब इस बच्चे की डेथ हो सकती है। आप इतनी देर से वेंटिलेट कर रहे हैं, हार्ट रेट इंप्रूव नहीं हो रहा है, दिस चाइल्ड कैन डाई, मामला सीरियस है। If the baby is not breathing, that expert will perform an endotracheal intubation, will start chest compression, may perhaps give adrenaline. इसमें प्रोग्नोसिस पार्टी को बतानी पड़ेगी, सब कुछ करना पड़ेगा, क्योंकि this is a situation where a seriously the child can die because of birth asphyxia. Thank you very much.
Yes, sir. Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, we have received some question. If you allow, can I take this question with all your permission?
Sure, sure.
So the first question I can see is, the question is that what is the targeted preductal SpO2 level 5 minutes after birth?
So you are talking about SpO2. Okay. So SpO2 after 5 minutes, even if suppose it is around 80%, it is good enough. Right? You will not get a SpO2 after 5 minutes के बाद में पल्स ऑक्सीमेट्री यदि आप लगाते हैं तो उस समय ऐसा बहुत बड़ा एम्बिशियस मत रखिए कि आपको 90% मिल जाएगा या सब कुछ मिल जाएगा, क्योंकि एट दैट पर्टिकुलर टाइम द फीटल सर्कुलेशन इज चेंजिंग टू अ नियोनेटल सर्कुलेशन. So even if suppose you have got 75 to 80%, that is, but what is more important is, rather than focusing on SpO2, बच्चे को देखिए बच्चा रो रहा है कि नहीं रो रहा है, हार्ट रेट उसका कैसा है, बाकी कलर उसका कैसा है, ठीक है ना. और इसको डिटेक्ट करने के लिए लेबर रूम में आपके पास में बहुत ही ब्रिलियंट मैसिमो टेक्निक का पल्स ऑक्सीमीटर होना चाहिए. ये नहीं कि कोई भी पल्स ऑक्सीमीटर से आप उसको डिटेक्ट करें. देयर हैज टू बी अ वेरी गुड क्वालिटी पल्स ऑक्सीमीटर टू डिटेक्ट SpO2 ड्यूरिंग डिलीवरी. पर यदि वो है आपके पास में, it's nice, wonderful, very good, do it, please do it.
Okay, thank you so much, sir, for explaining it really well, sir. I hope that the participant who have received this answer, who has asked this question, sir. Moving forward, another question is, what is the most important step when resuscitating a compromised infant?
Resuscitation क्या है? Compromise means फिर से थोड़ा सा बताएं.
Yes, sir, Zarur, sir. The question is, what is the most important step when resuscitating a compromised infant?
Compromised, what I have देखिए, what I have understood is, मतलब the question is in fact not very clear. Okay.
Yes,
But
sir.
well, I mean to say, if suppose compromise means if suppose there is a lack of oxygen, चीजें ठीक नहीं हैं, ठीक है ना, अंत में what is important is just follow the algorithm. आपका जो डिलीवरी रूम है उसमें जो भी एल्गोरिदम है उसमें एक एक स्टेप करके फॉलो करते चले जाइए. आपको जो असेसमेंट्स करने हैं असेसमेंट्स को करिए. उस असेसमेंट्स में देखिए राइट कि किस प्रकार से क्या ब्रेडिकार्डिया हो रहा है, क्या कोई ना कोई समस्या हो रही है क्या. अकॉर्डिंगली अपने क्लिनिकल साइंस को अलर्ट करते हुए राइट आप मैनेज करते चले जाइएगा एज पर दी एल्गोरिदम. एज पर दी एल्गोरिदम कॉम्प्रोमाइज सिचुएशन ये है कि भाई यदि मान लीजिए उसका हार्ट रेट गिर रहा है, if the heart rate is less than 100, then
In that situation, आपको हो सकता है उसको इंट्यूबेशन करना पड़ेगा, आपको एड्रेनलिन देना पड़ेगा, आपको चेस्ट कंप्रेशन देने पड़ेंगे, आपको सेंट्रल लाइन से सलाइन पुश करना पड़ेगा, आपको ये सब वेंटिलेशन करना पड़ेगा. इट ऑल डिपेंड्स अपॉन ए इंडिविजुअल बेबी. उस बच्चे का क्या सिनेरियो है, उस बच्चे की क्या सिचुएशन है, कितना वो कॉम्प्रोमाइज्ड है. सो उसके अनुसार आपकी प्रिपेयर्डनेस हर चीज के लिए रहनी चाहिए for anything that can happen.
Okay, thank you so much, sir. And sir, moving forward, sir, there is one last question for today's session, and the question is, where should pressure be applied when performing compression on the newborn?
Okay, very nice, very nice, very nice. Chest compression you are talking about. Now, chest compression is we have to apply on to the lower part of sternum. Sternum मतलब जो है कि बिल्कुल उसका जो है कि junction between 2/3 and 1/3 वहां पर देना है. There are two types of methods of giving chest compressions. One is, which was earlier taught, was a 2-finger chest compression. Now, 2-finger chest compression को आजकल देते नहीं है. What is important is कि हम दोनों हाथ को, जो दोनों पाम्स हैं, उसको रोल करते हैं और बच्चे को जो है दोनों एक के ऊपर एक थंब को रख के, दोनों मतलब एक के ऊपर रख के we give chest compression, sternum के lower part में देंगे, and we will ensure that साथ में bag and mask ventilation चलता रहेगा, and the chest compression rate should be around 120 per minute.
Okay, sir. Thank you so much once again for explaining this answer really well, sir. As I can see, there is no more question from the participant end. Sir, shall we conclude this session with all your permission?
Oh, yes, yes, yes. Okay. Thank you.
Okay, thank you so much, sir. And yeah, it was a really wonderful presentation from your end, sir. Till then, take care of yourself. Hope to see you again with different topics, sir. Thank you so much.
Please kindly note down कि जो भी आपके colleagues हैं